Hi everyone, I am Tara Menon. I am a second year medical student at Virginia Tech Carilion School of Medicine. I am interested in exploring ENT and also have an interest in plastic surgery, mainly because I love head and neck reconstruction. I thought Dr. Ong's lecture was super cool, so happy to have him as a moderator here. Um, but this is one of my interesting topics of interest, and I worked on it with my classmate who's also presenting as well in a different breakout room. So without further ado, let's get started. All right, so you have to start with a quote. "A smile is a universal welcome" by Max Eastman. You might be wondering who Max Eastman is. I'll be honest, I don't know either, but I liked the quote, so we're going to keep it here. And I do think it's true. A smile is truly a universal phenomenon, and we're going to dissect what a smile really is here as well. I don't know if you guys know this man in the corner. It's a meme. I just wanted to put a meme in the presentation as well. So the importance of smile, there's so many elements to it. It is a universal human expression. It is important in social connection. It can foster trust, cooperation, and positive social interactions. A smile can break down barriers and is often the first step in forming relationships. And ultimately, a smile also expresses happiness, empathy, reassurance without words. Losing the ability to smile can really lead to social isolation and emotional distress. And culturally, in almost all societies, smile is a key element of nonverbal communication. And as we know, medicine is a lot of nonverbal communication as well. And ultimately, it does impact a patient's quality of life. It affects their self-esteem, their mental health, their confidence. So being able to restore a patient's smile will restore effectively their identity and social presence as well. And so basically, there's so many origins for why facial paralysis can happen. I kind of picked cancer just to kind of narrow the scope down, but it doesn't really do that, as I found out. So there's a couple of reasons why facial paralysis can happen. There can be direct tumor invasion of the facial nerve. So, for example, the parotid temporal lobe skin cancers. It can be from an iatrogenic injury from surgery. Sometimes there is surgical sacrifice required of the facial nerve, or there could be inadvertent damage during the resection. And also radiation therapy can also lead to that as well through nerve fibrosis and so there's this multimodal approach to how this could happen. And so ultimately, as we kind of discussed, not only does it kind of take that ability to smile away, but in general, facial movement. So being able to frown, closing your eye completely. And I couldn't cover that in the scope of this, but they can do like gold weights in the eyes to help make that look a little bit more natural as well. And there's a risk of that corneal injury as well when you're unable to close the eye. And so you can kind of see in the image on the left and on the right. Um, you can see this patient had right cancer and had facial paralysis, but after 7 months, they had a transfer, 5/7 transfer and a fascial lattice suspension, which we'll cover. It looks a lot more natural. I'm sure it made a big impact on his confidence as well. So, I'm sorry. And so, not to cover everything, but just to see like there's so much etiology of facial paralysis and how it can occur from viral, infectious, inflammatory, trauma, iatrogenic, and congenital as well. And so the clinical challenge here is that often cancer patients do have other complicating factors like older age, comorbidities, need for adjuvant therapy, and scarring from prior treatments. So the goal here is to restore a dynamic, symmetric smile. And that is not as easy as it may sound. Or maybe it doesn't really sound easy either. So just to kind of cover basic anatomy and pathophys of the facial nerve, it's super complex, over 7,000 myelinated axons and of 10,000 total neurons like contributing to facial expression. There's 5 terminal branches like temporal, zygomatic, buccal, marginal mandibular, and cervical. And there's a segmental anatomy to also kind of consider when you are working in this area. So considering their lengths and proximity. That's kind of like the landscape of the facial nerve. Now, if we go to discuss how these cancer injuries happen, I kind of briefly mentioned, but it can be from tumor invasion. So when there's a parotid carcinoma or a skull-based tumor, some parotidectomies require surgical sacrifice. So it has to happen. And so that is an outcome that could occur. And then radiation neuropathy, as we kind of discussed earlier. And so there's kind of two time windows to think about, and the timing depends from paper to paper and source from source. It seems like 2 years is what I've kind of found. If less than 24 months post-injury, perhaps you could do nerve transfer. It's still viable, but if it's over that amount of time, it makes tissue transfer unnecessary, and nerve transfer is not viable at that point. So the uh, next slide is just kind of showing a visual diagram of the facial nerve and many, many branches. Not going to dive in here, but it's super complex. So you can imagine how, if there's a cancer, if there's a tumor kind of in the middle here, it's easy to affect so many things in our facial expression. And so how do we assess that in patients? So we can use this scale called the House-Brackman scale. It's a scale from 1 through 6, and it basically kind of grades the severity of the facial paralysis. So I think it's pretty self-explanatory. And they kind of consider things like eye closure, forehead movement, mouth movement, and synkinesis, which is like unwanted movement that kind of occurs. And this next picture kind of shows the severity when you look at static face. You can see the right side of this woman is kind of starting to face downwards. And when you look at the dynamic movement as well, it really also affects the eyes as well, and other aspects of the face as well. So this quick video, I'm just starting it from the 6 out of 6.
General groups. This last patient.
So I've just muted it, but this last patient has a 6 out of 6 on the scale. So just to show you the severity, the eye closure is not happening. You can imagine how that's pretty dangerous as well, just to navigate daily life. And probably takes away that self-esteem as well. So there are new innovations in the field trying to see how we can better evaluate it. House-Brackman has been there for decades. But eFace is a new one in a new paper, well, not new, but in the last decade, looking at how can we better assess this through a digital instrument. So they look at a little bit more measurements like static symmetry, dynamic function, synkinesis. And they say it's superior to House-Brackman, so that might be the future of the field. And so this table just kind of shows like the key parameters that they're looking at. And so this is just a little picture of what their online platform would kind of score. So just another cool development. Okay, let's get to the meat of this talk, which is looking at the surgical options. And oh my God, there are so many. So again, kind of throwing back to like that time frame, there is a reversible/acute time frame, which is roughly 2 years from the injury, and that you can focus on nerve-centric repair. So you could use like direct end-to-end coaptation, cable grafting through the sural nerve, or nerve transfers as well. And if it is irreversible, I think the gold standard is a gracilis free muscle transfer, that you could use a temporalis tendons transfer, and also static slings, maybe using the tensor fascia lata, for example. Just it's more so to look at the symmetry rather than functionality, which is what this table is trying to show. And so when we look at how many approaches there are, there's so many. I wonder if I can get this in time. Let's see. So primary repair is like very straightforward, directly reconnecting facial nerve ends, and you can imagine that's used when it's a very fairly recent injury, or things like that. Cable graft, similarly, it uses a donor nerve to bridge a gap between nerve ends. There's babysitter procedure that uses a mesenteric nerve often, just to kind of temporarily reinnervate the muscle while waiting for that cross-face nerve graft to mature, and that kind of is below as well. And the masseter nerve transfer will use a jaw nerve to reinnervate facial muscles. So when you instead of like wanting to smile, you have to consciously kind of clench your jaw to do that, which I think is very interesting. Could be a downside depending on how you look at it. But gracilis muscle transfer is now we're moving to those long-term, more so aesthetic changes. So it's able to transplant that functioning muscle from the thigh to face, temporalis tendon, and the static sling, as we kind of discussed. That will be just to suspend that mouth corner and make it look a little bit more symmetrical. So there's so many decision-making algorithm tree branches, and this kind of covers what we discussed. You look at how long the paralysis has been there. Is there a functional contralateral facial nerve branch? The decision-making tree is there, but it really is very personalized to the patient. And similar, this is another one that I like because it looks at, different aspects of the face. The upper part, you might need to do a brow lift or an eye salvage. Lower lip, you might need to do different things. So it's a very multifaceted approach. And I just wanted to include some pictures that I thought were cool. At least I found it really cool, like looking at a two cable serval nerve graft. Um, this I'll just quickly run through it on a 2 times speed. Sorry. Like this is super sci-fi-esque to me. I think it's awesome that they're able to do this. So you take the sural nerve, sorry, gracilis. Oh, sorry, yes, sural nerve, and I'll let the captions do the explaining, really. Take the gracilis muscle here and kind of take a small portion of it and able to kind of suspend um, that portion of the paralyzed side. And with some amazing microsurgery techniques, I think this is awesome and able to give back that confidence to the patient. So, and this is just an example of how a static sling before and after might look as well. So it's kind of, you can see it's a little apparent that they have something there, but it is helpful. And so there's a lot of emerging technologies. You might consider bioengineered like conduits, like stem cells, and using nerve bridges to match, which has matched autograft performance without needing to self-harvest from the patient. There's exosomes like nanoparticles that can be used from stem cells and load them with nerve regenerating molecules, so make it a little bit more faster as a process. And sometimes you can do like a preemptive facial nerve wiring before you even resect the tumor, which has apparently shown benefit in a patient. So that could be a possibility as well. And in terms of complications management, there's obviously, it's not going to be a perfect solution, but it is an improvement. And these things, you can do things like Botox when you get synkinesis, incomplete smile, might need physical therapy, may consider doing a static sling suspension if there's still remaining asymmetry at rest, so on and so forth. So it really depends on the case here. And so the key takeaways here is act early, embrace new technologies. They're always coming. There is there's a lot of personalized approaches that you can do. You need to consider the patient and their tumor type, their location, patient goals, and ultimately realize this a multifaceted approach. It's going to be a multifaceted team. So therapists, psychologists, like plastic surgeons, ENTs, so on and so forth, to consider the entirety of the patient. And so I did put a question. I think we're pretty short on time, but does anyone want to take a quick stab? It shouldn't be too hard, I hope. If it's a little difficult, I can go on. All right. Oh, sorry. I'll go ahead and answer it. So it is a early nerve repair grafting is preferred within 12 months if muscle viability is confirmed. The others are just like throw off options. It is because early nerve repair is preferred, as we kind of discussed. Static slings are kind of for patients who cannot undergo these dynamic procedures, so they're not immediately first line. And the others are different timelines and utilities. And so that is my presentation. Thank you so much for your time, and I'm happy to answer any questions if anyone has any.